Good afternoon and welcome to today's IPFCC webinar, The Role of Leaders in Advancing Patient and Family-Centered Practice. My name is Annette Lee and I'm delighted to serve today as your webinar host. Marie Abraham will be moderating today's webinar. To ensure an optimal experience, all lines are muted during the presentation. And now I'll turn it over to Marie.
Thanks, Annette. Welcome, everyone. It's great to have you all here. And I see by the poll results that we have a number of different disciplines joining us. So it's always great to see that. And I am Marie Abraham, as Annette said, and I'll be moderating today's presentation. And we certainly welcome your questions and comments. So feel free to chat them in during the presentation, and I'll make sure that Bev responds to them at the end of her presentation. Just a few words about IPFCC for any of you who are on the webinar today and are not familiar with us. We were founded in 1992 as a nonprofit organization. Our mission is to provide leadership for advancing patient and family-centered care in all healthcare settings. Well, we provide on-site and off-site consulting and training. We also offer publications, videos, and educational programs such as today's webinar. And we welcome you and invite you to log on to our website for more information. I want to just introduce Bev Johnson, who will be presenting our webinar to you. Bev Johnson is IPFCC's president and CEO. She provides technical assistance and consultation for advancing the practice of patient and family-centered care and creating effective partnerships with patients and families. And she's done so in over 300 hospitals, health systems, federal, state, provincial agencies, military treatment facilities, and community organizations. She facilitates visioning retreats, leadership concepts, leadership development, and the integration of patient and family-centered concepts into policies, programs, and practices. Bev currently serves on the selection committee for the AHA Quest for Quality Prize, and she's a member of the board of directors of the Patient-Centered Primary Care Collaborative and the Association of American Medical Colleges. In 2017, Bev was recognized by the American College of Physicians with the Edward R. Loveland Memorial Award, and in 2018, she was inducted as a fellow into the American Academy of Nursing. And with that introduction, I'm going to hand it over to Bev.
Thank you, Marie, and I'm just delighted to be able to have this conversation today talking about the very important role of leaders in advancing the practice of patient and family-centered care. I hope that this will provide you with some practical advice, and I look forward to your sharing what has been effective in your organizations. As with all of our work, we ground it in the core concepts of patient and family-centered care. I'll talk a little bit about the role, what we have seen in working with more than over 20 years, many senior leaders who are just key to advancing the practice of patient and family-centered care and creating the culture for this approach to care to thrive. And I'll profile a couple of specific organizations and the innovative way that they have gone about strengthening the partnerships with patients and families, and then close with some of the benefits of this approach. We've planned this webinar to reach senior leaders, and it's wonderful to see some of the people that we just saw at our seminar in Detroit on the call today, and we hope that they've brought additional leaders into the room with them. But we also have planned this for people who are not in the C-suite or an executive leader, but hopefully offering advice on how you can connect with them effectively to work together to make patient family-centered care foundational to your organization. So the core concepts of patient and family-centered care, we define patient and family-centered care as an approach to the planning, implementation, evaluation of health care that's grounded in mutually beneficial partnerships. And I want to emphasize mutually beneficial partnerships. And then there are 4 core concepts that your leaders should know and understand and reinforce and model in their actions. So first, all people are treated with respect and dignity. That's all patients and families, but that's staff as well. That you have systems in place to ensure that useful and unbiased information is shared with patients and families in an affirming way. The third core concept is that patients and families are encouraged and supported in participating in care planning, and decision-making at the level they choose. So that requires that both the culture and the selection and training of staff and clinicians know to support patients and families in that active engagement. And lastly, it's collaboration, not just in the clinical encounter, but it is collaboration in policy and program development, in professional education, in research, as well as in the delivery of care. And again, leaders can open that door for this kind of collaboration. A short way of defining patient and family-centered care is saying it's working with patients and families rather than just doing to and for them. It's a very important distinction, particularly when you begin to talk about the workforce and how they're selected and prepared. I would urge you, the leaders in the room and those who are seeking to influence leaders, to look at this article in the BMJ. It was published actually 10 years ago. Lucian Leap, the lead author, known as the father of patient safety. It's a very short article, and I think your key C-suite people should be very familiar with this article. And a portion of it talks about, for transforming healthcare, really as in the 21st century, a safety imperative that patients should be viewed as essential and respected partners in their own care, but also in the design and execution of all aspects of healthcare. So that's that partnership in improvement in safety. And this next statement, I think, is particularly important since the key authors of this article, many of them were involved intimately in the Institute of Medicine's Crossing the Quality Chasm. And in that report, I only wanted to add one word, and that was the word family. And here they say, organizations publicly and consistently affirm the centrality of patient and family-centered care. That should be reflected in your organization's vision, mission, philosophy of care, so everyone at all levels understand this partnership with both patients and families. They further in this very short article, they talked about the families really shouldn't be thought of as visitors in any part of the hospital. And in ambulatory care, the concept of self-management for people living with chronic conditions should be a central part of the way ambulatory care is provided. Several years ago, Don Berwick spoke at our international conference, and he talked about the triple aim, where he said that the most direct route to the triple aim is via patient and family-centered care in its fullest form. And so Don was thinking about these 3 aspects of the triple aim: patient experience, the health of populations, the communities you serve, and reducing costs. And that really patient and family-centered care is a strategy to achieve those aims. When the idea of the triple aim was expanded to talk about the quadruple aim, that's referring to that we need to, at the same time achieving the triple aim, we need to create a better work environment. and be concerned about the well-being of staff and clinicians. And again, I think patient and family-centered care is really a better way of working. It brings joy back into practice. It may be a slightly different way to work at the beginning, and so you have to support, and leaders need to plan to support staff in learning a new way of working. But ultimately, it is a much better way to work. Another resource for leaders that I think is important that they're very familiar with is it was still called the Institute of Medicine when this book was published, Best Care at Lower Cost, The Path to Continuously Learning Healthcare in America. And I think this book is very relevant to both our friends in Canada and the U.S., and it really talks about this partnership and how individuals are involved in their care decision, but also in health system learning and improvement. They further underscore that they should be helping us develop healthcare processes, how we create and apply technology, and the training of clinicians. So important ways that we should be partnering with patients and families if we want to have cost-efficient health systems. And this is a wonderful article by a physician leader and other leaders in healthcare about a key lever for leaders. They rewrote this paper to include the concept of putting patients and families as advisors in a position of real power and influence, and using their wisdom and experience to redesign and improve care systems. For high-performing health systems, the leaders of these organizations said this is the single most powerful transformational change we have done. So thinking about having patients and families in key positions of influence as a way to really bring about innovative and transformational change in your organization. I think another resource for leaders and for all of you on the phone, the American Hospital Association for a number of years has had an award called the AHA Quest for Quality Prize. The criteria has recently been updated, but it really does look at leadership commitment at the board level, at the senior executive level, and it's looking to see, I interpret it as how we align quality, safety, and patient and family-centered practice, and in ways that promote health equity and reduce disparities, that are really looking at community health and well-being, not just treating illness. And it's definitely looking for organizations where the leadership is speaking to partnering with patients and families, both in their own health care, but also in improvement and transformation. This is a $75,000 award. I think just the process of applying helps leadership understand these are criteria we should be paying attention to, and the process of applying provides a learning that's important for organizations. You may want to study the application and then work on it for a year and then apply the following year. It's an annual award. The deadline for proposals is September 30. I think we've seen over the last few years, certainly in the United States, a growing commitment to partner with patients and families. CMS and its innovation, both in hospitals and ambulatory clinics, is seeing across all settings and across the continuum of care, patient and family engagement. This partnership with patients and families is essential. In Canada, their Accreditation Canada captures and cites the core concepts of patient and family-centered care in their accreditation standards for all types of healthcare facilities. So if you're part of a large health system and you have ambulatory care, you have First Nations care, you have acute critical care, all of those, the expectation is that they all will have the foundational culture of patient and family-centered care. It's true for all behavioral health, mental health, and addiction services as well. And so speaking of Canada, and I see that we have some folks from Hotel de Grace in Windsor, Ontario. They've had a very interesting process with huge change in the healthcare systems in their community. It's a very unique community hospital that was formed 5 years ago through realignment in the region. So it really provides non-acute care services. Originally, it was providing acute services. So there's been tremendous change in the what healthcare services they are delivering. So you can see here ambulatory care, mental health and addiction, mental health for both adults and children, rehabilitative care, and hospice and palliative care. And Joanne Desjardins, the patient advocate, had appointed carefully selected 5 patient and family advisors to be her partners to build a really robust patient and family advisory council, a PFAC, and other advisory roles. She started this a little over 5 years ago, and just as the community was realigning what different hospitals would provide, she arranged for an organizational assessment with a strong education component to build on the current senior leaders' understanding and commitment to patient and family partnerships. But because of the major changes in what the hospital was going to be delivering in terms of shifting from acute to non-acute services, she and her team spent really the first 18 months just building trust that people could work together. And then she was ready to recruit more advisors. And increasingly, I'm seeing this all across North America, that people are putting ads in newspapers telling about the partnership that the hospital or the health system is considering. She received over 100 applications and interviewed almost 80 people to put together their advisory program. Senior leadership is so important, and Janice is current president and CEO. She was, prior to this, the chief nurse executive. But she said very clearly, which is so important for senior leaders to convey this to all levels of staff and clinicians, to their senior executive colleagues, and to frontline staff as well. Partnering with patients and families is not only important, it is expected. And all her senior team is supportive of these partnerships. This is how you really begin to shift the culture and build these partnerships into the foundation. You can see here that, and I hope you can see it, it's a fine print, but on the left-hand side of the screen is the Patient and Family Advisory Council, and it does have a dotted line reporting to the Board of Directors. I'll tell you a little bit more. This year they produced a report, a PowerPoint report, and these next 2 slides are drawn from that report, where they helped the Board of Directors see these are all key committees where patient and family advisors are serving. So this is an important next step. Having a PFAC is just the first step, but really embedding advisors. We always recommend at least 2 on a key committee. But you can see how when you have advisors, there are 12 or 13 committees here, that they're going to infuse their perspective throughout the organization. And then also in the report, they talked about their past accomplishments, a number of things in terms of changing the policy about visiting to really more of a family presence policy, working on the hospital website and patient guide, which is really the front door in many ways to the organization. They edited, and this is ongoing, a number of publications. They were very actively involved in the accreditation process with Accreditation Canada, and you can see they've developed their own logo, so you can see what the Advisory Council has reviewed, another best practice. And they now have, they've built the trust in the relationship. They have a patient advisor serving on a board level quality committee and as a voting member. And an advisor is also finishing her first year as a non-voting member of the board of directors. And I think as in a wonderful spirit of improvement, the advisor asked to meet with both the board chair and the CEO to reflect about the past year's experience. This is a new experience for boards and for patient and family advisors. And I think it's great to have this touch-base time to look at how did it go, how could it be improved. A couple of other health systems that are in the U.S. that I think are exemplars for moving forward with patient and family-centered care. At Beaumont, the largest health system in Michigan, they have 8 hospitals and home care and skilled nursing, long-term care, as well as a large number of clinics. There is strong commitment from the Board of Trustees, the CEO. The Chief Nursing Officer is very knowledgeable about patient and family-centered care. She's been a lead for that in 4 different health systems, and she is the executive champion of this work. They integrated, you can see where in their vision, so the best practice from that BMJ article that I shared with you, they have integrated the core concepts of patient and family-centered care at the center of and foundational to the way they do the work in their organization. They have embedded in the strategic plan. And when they first started this in 2016, they focused on eliminating restricted visiting hours, implementing family presence and participation policies, and getting site-based patient and family advisory council. They've also, another best practice for leaders is investing in education, both for senior leaders and for mid-level managers and frontline staff. And that's an ongoing process that they have been doing for the last 3 years. And most recently, I think this is a very innovative approach to the use of personal stories. We all know the power of story to help change people's attitudes and practice. And what they have begun this year is to invite their senior leaders, chief medical officer, the chief legal counsel who's in charge of risk management, shared their personal stories, which had an amazing impact across the health system, to understand that even people in those positions of power sometimes have trouble getting the health system to work for them, and or they have beautiful stories of what connection with family can really mean. They've set a very audacious goal of becoming the exemplar for patient and family-centered care in 2022. So there is real alignment between the board, the senior executives, and frontline staff, along with their patient and family advisors, to all work together to achieve that goal. North Mississippi is a very large system in a very rural area of the U.S., and they have combined patient and family-centered care with their high reliability work. They have a very robust performance improvement system. They're very committed to a culture of safety and to leadership development. But they felt that if you align and can get the synergy between high reliability and patient and family-centered care, that will be key to their culture and their health system. And you can see here the kinds of leaders they have invested in their leadership development for these key people in a significant way so they can guide it throughout the health system. Anne Arundel is a slightly different kind of hospital that is in the large, very successful community hospital in Annapolis, Maryland, in the east. And you can see in 2010, they were a high-performing hospital, but they didn't really know anything about patient and family-centered care, as their chief senior leaders admitted. And so if you look at what they've accomplished in 9 years is very exciting. Again, they started off with the chief operating officer and the chief nursing officer as a combined position ultimately, and she was the executive sponsor. They set, and I will show you in a second, annual goals for patient and family-centered care, which are approved by their board of directors. And today they have 17 members of their Patient and Family Advisory Council. They have 2 excellent patient and family advisors as chairs and 96 active advisors. They have very commitment of the chief nursing officer, chief medical officer, chief operating officer, who regularly attends their council meetings. So here's another pearl, I think, for leaders, that you want to make sure that at the highest level, you are setting operational goals to advance the practice of patient and family-centered care. So from the beginning, starting in FY 2011, they have had 1 or 2 priority changes to create more of a culture of patient and family-centered care. And you can see on this list, sometimes they couldn't achieve it in 1 year, and so they work on it a second year as well. But I think this is where strategically it makes sense. It gets the attention of senior leaders, it holds people accountable, and it assures that progress is being made. Just a couple of outpatient examples from now traveling way far west in Oregon. Here is another best practice. So it's very clear in that this is a large multidisciplinary group practice, medical group, and there are 3 major leadership committees: the Quality Committee, the Finance Committee, and the Patient and Family Advisory Council. That's circled in red, and they report to the senior physicians for this large medical group. So it's really making a clear statement that they are important to the ongoing success of the medical group. And then in a different medical practice, a group practice, I think this is such a wonderful example of the role of leaders. In quality improvement, they were realizing that people didn't use the after-visit summary, and patients went away with not always having the useful information they needed. And so they worked together with patient and family advisors over a number of months to really change how they handed out the after-visit summary, and they developed posters, and they really looked at that process. But here's what leaders did that's so wonderful. The chief medical officer, Dr. LeBlanc, followed up, recognized the hard work of advisors, and invited them to present to leadership in the medical group, and they had data. They were disciplined enough to collect data that would show the progress that they had made. So that's what leaders can and should do. Now, some of you I know want to connect more with the leaders of your organization. And I think it's really important to understand the perspective of leaders. What's important to them? What are the priorities they're working on? What are their concerns about the health system? What's there on their worry list? And then think about how patient and family-centered care could help them address those worries. I think it's always helpful to have really specific examples from your organization or other organizations about what patient and family-centered care looks like in a particular policy or program or practice. And be prepared to talk about what value. I mean, if this isn't improving things at your health system, then it's not such a good idea. We need to make sure that we're really adding value. And I think it's helpful because for many leaders, they really don't know what this really means. They may think it's a frill or soft stuff. They may not realize it's fundamental to communication, to relationships, to quality and safety in their organization. We just did a seminar. We had always welcome leaders at our in-depth seminars. We'll have an international conference in about a year, and there are a number of ways that we can connect with leaders that might be helpful to you. I think it's also important that if they say, I don't know why we need patient and family advisors. We have a very highly talented staff. Why do we need this other perspective? And they may push back with some of these things. And, that they're very busy. We don't have time for this. And if you can say, one, it won't take much of their time, but that it is time well spent because you will learn things about your organization you didn't know before. And I'll just give you another example. They're worried about sharing their dirty laundry, that they will show that the hospital is not perfect or that there are some problems or issues. And, transparency is really a good thing. And in most situations, patients and families may already know about these things, and they can help you in solving them. So just be prepared to answer those. Here are some resources available through IPFCC that may be useful. They're all on our website, and you can have them and use examples from them in talking with your leaders. We also have on our website some wonderful conversations that StoryCorps helped us develop, and this is Jim Conway, a wonderful executive leader, and he talks about his work as over many decades in really being a champion for patient and family-centered practice. So now I'm going to fly through some of the more specific best practices and roles for effective leaders that are not connected with an individual organization, but in our experience in working with so many senior leaders over more than 2 decades, this is what we are seeing that makes a difference. So one is that the senior leader makes an explicit commitment to partner with patients and families, and they provide resources, not a lot, it's not that costly for the benefit that they will give. But they also recognize that these partnerships with patients and families are key to quality and safety. They can help you, prevent errors, to promote a safe culture, and to engage in dynamic and meaningful quality improvement. I think it's also this commitment to partnership is to involve them in strategic initiatives. For years, I chaired strategic planning for a board of trustees of an academic medical center. And I think that patients and families bring insights about what should be on the strategic plan that complement what physicians and staff and leaders want to do. And we also think they should be measuring the outcome of the partnerships, because we need to be held accountable that we are making a difference. And recognizing also that building trust in these relationships takes time. And so you want to work on building the trusting relationships to ensure that you can sustain effective partnerships. Jim Anderson, former chair of the board and CEO of Cincinnati Children's, always said about working with patient and family advisors, get started before you're ready. And just be open about, we're going to learn how to work together, but we're going to get started today. Another best practice for effective leaders is to appoint a staff liaison to facilitate these collaborative endeavors. And it should be an individual with strong facilitation skills and who is comfortable communicating with patients and families, but also comfortable in communicating with organizational leaders. You want to make sure that you develop the vision of your organization through a collaborative process that involves staff at all levels, clinicians, and patients and families, and that that somewhere in this vision, mission, philosophy of care, there is the expectation for partnership. We see that when it's not there, when it's missing at that high level of the organization, it often doesn't become meaningful. So it needs to be embedded in those key documents. And I think when you're thinking about large health systems, as both in Canada and the U.S., we seem to be merging and getting larger and larger systems, you want to make sure that there is room for the uniqueness of councils in different parts of the system, but all working towards the same general vision. This diagram here offers one way to look at the structure of the infrastructure for supporting, maybe in your health system or your hospital, multiple different PFACs. And with those little circles on the outside, those are patient and family advisors serving on committees. We really think to have a steering committee or an oversight committee is very important. And I know one of you asked about that they are very useful in opening doors, the steering committee. They provide oversight. If there are challenges, that you can brainstorm with them, and they become a central coordinating oversight for all the different patient and family advisory councils or all the different roles that patient and family advisors might have. So your exact title of your councils might be different, but this is an idea of the way you can show the infrastructure. At Children's Mercy in Kansas City, their leaders developed a video and a policy paper that said we are going about working on quality and safety with patient and family advisors. They must be part of all of our efforts. So all of their committees on hospital-acquired conditions have patient and family advisors serving on them. One of you asked about how to link patient and family advisory council to quality, and I think this is, one way that they select and mentor their advisors thoughtfully. You can see on this organizational chart that their patient and family engagement work reports directly to quality. So again, that may work in your organization. I shared with you earlier at Beaumont, the nurse executive is that because of her unique experience in patient and family-centered care, I think that One of you asked a question about how else. I would invite the quality director to your patient and family advisory council to discuss what are the priorities that the hospital is working on. Let's have a discussion about how patients and families might be able to help you in that work. I would send your minutes for your PFACs always to the director for quality and the director for safety. And I would, on a regular basis, like every meeting, have quality and safety as agenda items. So that's one way to begin to connect this work. In terms of the board of directors, I think it's extremely important that they are knowledgeable about what is patient and family-centered care and how can it relate to the responsibilities of board members. I think hopefully most organizations in North America will invite experienced, prepared patient and family advisors to serve on the board of directors. But I don't think you just put anyone there. You want to make sure they're qualified, they have experience as an advisor. And I think it's extremely important that every PFAC or Patient and Family Advisory Program reports annually to the board, and best in person, but they should have a written report as well. And when you think about it, boards are engaged in the following key activities: developing the vision, mission, and values of the organization, strategic planning, selection, evaluation of the CEO, quality assurance and improvement, safety, stewardship of fiscal resources, and performance improvement. And in each of those, we've done, and we're happy to come and do educational programs for boards of trustees and senior leaders on site for a health system. We've done that statewide and for specific health systems. And I'll give you some further ideas about how you can relate to both your senior leaders and your board. I think it's important, while this work is beyond just HCAP scores and the experience of care, I think that leaders need to believe that the experience of care matters to quality and safety and the fiscal performance of the organization. And so they are constantly making that link for others to see. And you may have a specific vision for your whole health system and for specific departments. Another way to have an articulate commitment to patient and family-centered care for a specific clinical area. The vision, this is one of our publications. If you're developing a vision, mission, and philosophy of care, we do this facilitated on site, but we also have published a book that you can have and use many of the ideas we've used in lots of different places. I think that I shared with you the power of sharing stories and what Beaumont was doing with their chief medical officer and their chief legal counsel. But this is Privileged Presence as a book of stories that other organizations have given to their leaders to help them share stories from the book, but also help maybe even collect stories like what is recorded in the Privileged Presence book to share with others and to maybe even put together your own book for your health system. Another thing that effective leaders do is they conduct safety rounds and leadership rounds. So they're up on the unit and in the clinics, meeting people, asking about quality and safety. But what a great idea it is to include a patient or family advisor who's been selected and prepared to accompany senior leaders in this type of round, really bringing a different perspective and insights and contributing to the positive, supportive conversations. And the most expensive part of managing a hospital or health system is human resources, your workforce. It's not the bricks and mortar of a building, but it is the workforce. And so leaders select the leader of human resources carefully and ensures that this team in personnel in human resources really understand that you integrate patient and family-centered concepts in every aspect of human resources to build a cost-efficient, highly skilled, committed workforce with the right attitudes, and so that they appreciate and understand collaboration and those 4 core concepts of respect and dignity, information sharing, participation, and collaboration. So they learn to, and we have an assessment tool that's on our website, that you embed these concepts in how you recruit, how you hire, even having patient and family advisors on some of the selection committees. You embed the concept of partnership in position descriptions and performance appraisal. And then you certainly embed this in orientation. I heard from a leader recently of another organization that had embedded recently their patient and family-centered care is a key part of orientation, sharing of stories, understanding those core concepts. But what they realized was that a lot of their staff didn't have that when they went through orientation. So at each new orientation, they invite some of their current staff to attend the patient and family-centered care orientation session. And we always think it's great to have a recognition and awards program to really encourage this practice. And certainly, sometimes it's embedded in human resources, sometimes it's in leadership development, sometimes it's in organizational development, where there is a comprehensive education plan for building the skills of both leaders and frontline staff. And it's important that you also have a system in place to hold people accountable for patient and family-centered practice. Some of these issues are really tough. It's not all easy in today's complex world. And so leaders can create a climate where, it's not going well, or we don't really understand how to do this, and we want to talk about our concerns in a way that we won't be ridiculed or embarrassed, but really it's a safe place to talk about the more challenging issues and figure out how to address them. Then further ideas, we've talked a little bit about embedding this into the strategic plan, how you're going to advance patient and family-centered care, that I've seen very effective in health systems where every department, and that could be finance, housekeeping, a clinical department, IT, has a goal to advance the practice of patient and family-centered care. And then they have to track it, measure it, and they get rewarded for making change and improvement. It's always helpful when you set the expectation that with that goal, they develop it with patients and families, and they implement the goal with patients and families as part of that process. Certainly, the Board of Trustees and senior leaders are very involved when we start spending dollars around design, planning, renovation, building new facilities. And that's another way that you want to make sure that leaders say, we're not going to go ahead and build the new radiology suite without patients and families part of the process. That's just one example. And you can look on our website for lots of ways that patient and family advisors can help in design, planning, and renovation and new construction. Now, there are lots of emerging issues. This is such a complicated time in healthcare. And it's important to think about, okay, now patients and families have helped us with a lot of our current work, but what are some of the emerging issues and how could they help us? Well, one of them certainly is the opioid epidemic. And we've been concerned at PFCC for a while that we're not really significantly partnering with people with lived experience, individuals and families. And many patient and family advisory councils have not really begun to ask questions and begin to help in addressing issues related to pain management and the opioid epidemic. We have a white paper on this topic and some wonderful video clips that I think you would find useful on our website. So I hope that you will begin as leaders to involve people with lived experience in your opioid work. And then another really emerging issue that sharing clinical notes openly with patients and families. This is an example, an article that showed some of the benefits of sharing open notes, but also there was initially pushback that, oh my goodness, at the University of Vermont, I'm not sure we can do this quite yet. But it was leaders that said, if we're truly committed to patient and family-centered care, we need a best practice is sharing open notes, and we need to move forward in how to do that. And they prepared really well. They had advisors on the planning committee along with clinicians, and the process has gone very smoothly. I think another trait I found in effective leaders is that they're very open to new ideas. They have a can-do attitude. That fosters innovation in your organization. It sets the tone for innovation and transformational change, and it really encourages risk-taking. You need to be supportive. Not everything works. And so that's an important. And then it's important to track and measure a change. We have a dashboard. It's in your materials. You could create this all on your own. It's a simple PowerPoint slide, but you want to measure the number of advisors, how they're being involved, what impact they're having. You can link it to both quality and safety and to some of your HCAP scores. We recommend these questions that are in the public domain. They're also part of the custom questions for Press Ganey, but they help you measure from an experience of care, I think, better than some of the traditional HCAP measures. I think it's very important to celebrate success. One hospital leadership has a Thanksgiving turkey every year, and this is a diverse and underserved community, and they really appreciate this special Thanksgiving dinner. At Anne Arundel Medical Center, we talked about them earlier. I was so pleased to be invited to attend this celebratory dinner, which all was on a theme of the puzzles, putting it together, and how patients and family advisors are key to putting the puzzle together. It was a wonderful celebration, and here's a picture of some of the advisors that attended that lovely dinner. And this is the CEO who jumped up on a chair to take a picture of the advisors, just conveying, how supportive she stayed the entire evening, taking notes, just absorbing all of this wonderful work around partnerships. And here are examples of patient and family advisory reports that I think you could look at on our website to get examples if your organization isn't already doing one. And so lastly, I just want to touch on a couple I've tried to throughout talk about outcomes and benefits. This is the study we did in New York of PFACs and PFAs, looking at their prevalence and functioning in hospitals in New York State. And we definitely could see a link to some of the safety metrics related to pressure ulcer, sepsis, and 30-day readmission. And for hospitals with a PFAC, regardless of whether it was a high or low performing. We also saw that hospitals with high performing PFACs had significantly higher HCAP scores. In addition, one hospital in Illinois did a study on pain management, and they used and worked for over a year with a PFAC just focused on pain management. They made significant changes, and they exceeded their expectations much faster than they thought, with higher scores for HCAPs when they introduced the new pain management measures developed with the PFAC. And here's another example from really quality improvement in behavioral health and emergency room, where they very carefully measured the impact. Not only did they reduced the number of aggressive acts in the ED and the number of patients with psychiatric concerns who left without receiving care, but they also improved the discharge plan and reduced the number of psychotropic drugs. And again, best practice for leaders, they celebrated this collaborative work with the patient and family advisors, clinicians, and community providers together. And the CEO is in the center next to the family leader. I think leaders now are seeing that patient and family-centered care is a powerful business transformational tool. So I know I've gone fast today. I hope I've given you lots of ideas. There are a number of handouts that go along that you can get with this presentation in addition to the slides. I'm happy to take questions, and I think Annette or Marie may have some other thoughts to share.
Thanks, Bev. We have had a question chatted in. We have time for probably one or two more. So if you have a question for Bev, please chat them in. So the question was on specific preparation for patients and families on boards. What are some specific things that they need?
Okay. I think one is, I think it's very important to select an experienced patient and family advisor. And I think they need to understand the role of boards of directors, because it's high-level work. It's not the work on a patient family advisory council or on a committee of a council. It's really more into the weeds and really working on something. But at the board level, you're talking about policy and bigger issues. So we find it useful. I listed in this, the 7 major functions of a board. And if any of you attended our Detroit seminar, I did a whole session just on that, and it takes each one of those 7 roles and talks about what's the role of patient and family-centered care and the role of an advisor. I think it's very important that advisors read some of the minutes of past board meetings so they understand the kind of work that they're doing. It's very important that they meet with the chair of the board, perhaps a couple of the chairs of committees. I think it's very helpful to prepare the board for working with patient and family advisors, because they may not know how to work with them as well. And so that kind of preparation, some of the basic preparation that you would do for patient and family advisors is also relevant to serving on the board. We have an article that is in draft that we are hoping will be approved soon and will be submitting for publication, and that may be a resource. We'll let people know. It'll be on our website or in our e-newsletter pinwheel pages, but I think it's a great question.
Great, Bev, thank you. We have one more question, but we only have 1 minute left. So I am going to suggest that we respond to Catherine's question via an email after this webinar is over. If that's okay with Catherine, I will definitely respond to you. Bev, I just want to thank you. I want to thank everyone who joined us today on the webinar, and I'm going to hand it over to Annette just for a few final comments. Annette?
Thank you, Marie, and thank you, Bev, for the presentation. So just a few things. I just want to mention that we do have our free online learning community, PFCC Connect. If you do have any additional questions that you want others around the country that are working toward the same goals to answer, you can also share things that you learned here and kind of discuss anything related to patient and family-centered care. So it's a great tool that you can find resources and all these other things and connect with people. So you can just go to the link that you see on the screen right now. All right. Thank you for joining us today. Within the next few days, I'll be sending you a certificate of participation and a link to access a recording of the webinar. And in that email, you'll also have all the handouts that Beth mentioned earlier today. A very short survey will appear after this meeting ends. Please take a few minutes to share your thoughts with us, as it helps us improve the content of our webinars. Lastly, please feel free to contact us at IPFCC if we can further assist you in your patient and family-centered endeavors. Thank you for your participation and have a great afternoon.